So the basic mechanism is they bind to the melanin in the RP and it inactivates the lysosomal enzymes. So the animal study has shown damage to both the layers. However, in human study, in early stage, what we see is the outer retinal damage. This is an extremely late presentation where you classically see the bullseye maculopathy. And if you see that same area on autofluorescence, you will see a hyperautofluorescence in the early stages. And down is the OCT, the same area where you can see the arrowhead. There's loss of those inner layers. And the typical sign what you see here, it's called as Francis sign also. This is however seen in very advanced stage of toxicity. In our Asian population, it's seen little bit in the extramacular area. So the extramacular area should be concentrated whenever you're doing the OCT. The same thing, wherever you see the arrowhead, the inner layers are lost. So this is the first sign which you should try to pick up in your practices. And the corresponding field loss also you can see. Now coming to the dose, the recommended dose is less than 5 mg per kg of real weight. This is very, very important. So whenever the patient walks into your clinic, just ask what is the dose of HCQ you are taking. Usually the tablet comes in 200 mg as single tablet. So you can ask whether the patient is taking a single tablet, two tablet or two tablet morning and evening. So that will give approximately how much mg he is taking. If according to his body weight it is more than 5 mg, he becomes a high risk category. The risk of toxicity within first 5 years we have not seen. So the more the duration, the more the toxicity, and the risk increases rapidly after 5 years. The excretion of this drug is also to the to kidneys. So any renal disease, these patients are more susceptible for HCQ toxicity. Patient having associated taking tamoxifen also increases the risk, as well as if patient has any maculopathology also increases the risk. So the goal of our screening is to recognize these early signs and to prevent the loss of vision, not to stop the drug at the first borderline abnormality. So what is the frequency you should screen? So at the first go you can have a baseline screening, and then later after 5 years you can screen every yearly. So the annual screening basically starts after 5 years of usage. However, you have to do the screening faster in case the dose is more, or if the patient is having some renal pathology or any maculopathology. What are the tests you have with you? You can do either spectral domain OCT, fields, FAF or multifocal ERG. However, the most important test or screening test is a spectral domain OCT. The one which are not recommended are fundus examination, time domain OCT, FFA, full field ERG, ancillary color testing and EOG. Field test, one major disadvantage is there is lot of false positivity and it really depends on the subject. So the most thing what we advise is a spectral domain OCT. It's very objective, highly specific. It can be repeated every time the patient comes. Once you find a defect in that, you do a corresponding field test. Whenever you advise a field test, go for a 24-2 or 30-2 rather than 10-2, because in our population, in Asian population, it is seen around the macula. It's not seen around the fovea. So if you do a 10-2, you may miss, especially in our population. So go for a 24-2 and a 30-2. And STOCT, I already told there is specific loss of layer, and with the corresponding field changes, you can come to a definite conclusion that patient has started the toxicity. If you have any doubt, you can go ahead with perimetry or multifocal ERG, or nowadays if you can go even with autofluorescence, where in the early stage you will see hyperautofluorescence, and later stage because of complete damage, you may see a hypoautofluorescence also. So the recommendation is go ask for a dose whenever the patient comes. It should be less than 5 mg per kg body weight. Baseline examination, once the patient comes, you can do, and then after 5 years, do it annually. Each visit to a spectral domain OCT. Fields, if you are doing, ask for a 24-2 or 30-2. aim is to identify the toxicity early before the RP damage sets in. Once it is there, you can discuss with the physician before telling the patient, because this may be a life-threatening disease modification drug. So you can't just tell the patient and he may stop. So you discuss with the physician first, then confirm that with the patient.